Hi, I'm Dr. Sherman Silber, the Infertility Center of St. Louis, and I'm ready to answer any questions you might have. Just come up with whatever is concerning you or on your mind about infertility, and I'll answer them the best I can.
We have a question from Lucy. We live in Georgia. Do you help patients from out of state?
So the question is, this couple lives in Georgia, and do we have patients from out of state? Well, actually, of course we do. Over half of our patients come from all around the world, actually, so Georgia is relatively close. No problem. We really try to time everything so that you need to spend a minimum of time actually in St. Louis. I mean, people come from the other side of the globe, really. And normally we can limit your stay for an IVF cycle to just 7 days or less, because we know what you can do beforehand, and we can let you leave as soon as we get your eggs. And so we're very adept at planning things really well by phone and email so that you don't have to spend a lot of time here.
Are there any side effects to IVF and the medications?
Oh, well, this is a real question. Are there any side effects to the medications in IVF? Well, absolutely right. I mean, there is the terrible syndrome of hyperstimulation syndrome, where the ovaries get huge and you secrete a lot of the hormone estrogen into your abdominal cavity, and that causes fluid to be sequestered into your cavity, and you get dehydrated peripherally, and your belly kind of swells up and inhibits your breathing. It's a terrible, terrible, dangerous complication. We avoid that 100%, though. We avoid it 100% by doing mini IVF, by triggering your ovulation maturation with Lupron rather than a huge dose of HCG. And although it used to be a real serious problem, we just don't have that problem, that risk anymore at all, really. That should not be a fear. Now, of course, anytime you give hormones, there may be mood changes and swings and and just the overall bad feeling. And we minimize that with a mini IVF protocol, where we really get a minimal elevation of the hormones and get a smaller number of better quality eggs. And so we have great pregnancy rates without putting you through what is really an ordeal for most couples going through most IVF cycles. It's really an ordeal for them. But we avoid that with our mini IVF protocol.
We have a question from Cynthia. Can one go through IVF and a transfer with a blocked tube or scar tissue?
Well, that's the question. What if you have a blocked tube or scar tissue? Can you go through IVF? Well, clearly that's one of the very obvious reasons for doing IVF, is to bypass the blocked tubes. In other words, to retrieve the eggs through a little needle through the vagina, with you asleep, of course, fertilize the eggs, and put the embryos then back into your uterus, so there's really no need for fallopian tubes. However, something you have to be very, very careful about. If we see that the tube is blocked on what we call the distal end, or the fimbriated end, or the end near the ovary, not near the uterus, then it will fill up with fluid, and we'll see that on ultrasound. And that dilated tube is called a hydrosalpinx. It's a fluid-filled tube. And that fluid then drips backwards into your uterus and prevents or lowers the chance of implantation of the embryo. It's like a postnasal drip. So if someone has a tube that's blocked near the end where the ovary is, not the uterus, and we see it on ultrasound, then before doing the embryo transfer, that tube should be removed laparoscopically in order to give you the highest pregnancy rate.
Do you work with couples using a surrogate and an egg donor?
The question is, do we work with couples that need a surrogate and also need an egg donor? Yes, as a matter of fact, that happens commonly, that a woman may have completely run out of eggs and need an egg donor, but her uterus may also be scarred or even absent, or filled with terrible myomas that came back after surgery. And so women with a uterus that is not going to accept an egg, certainly in this country, we have no problem finding gestational surrogates. In other countries, it's illegal and it's difficult, and they talk about uterine transplants, which are very, very dangerous. You've heard of the terrible results in the United States with some of the premature attempts at doing this. And so a uterine transplant, it's something we could do because we're very, very adept. We're the earliest microsurgeons and probably done more microsurgery than any other center in the world. But we think it's much safer to go with a gestational surrogate. And what if you have, what if you want to have a baby, you have no eggs, and your uterus isn't any good? Well, many couples will go with donor eggs, their husband's sperm, and then put the embryo derived from donor eggs and their husband's sperm into a gestational surrogate. And we really don't have any unhappy cases of people that have done this.
We have a question from Ashley. My husband has been diagnosed with asospermia. We are unsure if the cause is obstructive or non-obstructive. What options do we have as we are not ready for donor sperm?
Right. Well, we really don't have to use donor sperm in most of these cases. This is a case where the husband has asospermia, meaning no sperm in the ejaculate. And it's caused either by obstruction or it's caused by either no sperm production or a very low amount of sperm production. So I just saw a patient today, as a matter of fact, that was not sure about this. And the first question to ask is, does he have a very tiny volume of ejaculate, like a fifth of a teaspoon, or does he have an ejaculate volume that's normal, like a full teaspoon? And believe it or not, that really tells you the answer right away about whether he was born with congenital absence of the vas or not. So if he has a tiny volume ejaculate, then that's really good news, because that means he's going to have normal sperm production and he just was born with an obstruction. And I just saw a patient today that I relieved them about that because it will be very easy to derive sperm. Of course, we invented that procedure many years ago in 1990. We perfected the ICSI in 1993, but we actually were doing the sperm retrieval as early as 1986 when we first reported that approach. Now, the other cause of not having sperm in the ejaculate is more difficult, and that's non-obstructive asospermia. And we first coined that term, and that means no sperm in the ejaculate, but there's no obstruction. So it used to be thought there was absolutely zero sperm production, and there was no hope for these people other than donor sperm. But then we showed that 60% of these patients have a tiny amount of sperm production, really, really, really tiny. But we don't need many sperm. It's not enough sperm to spill over into the ejaculate, but there is sperm in that testicle, and we can find that sperm in 60% of cases. And we hardly need many sperm. 1 sperm or 5 sperm are really all we need to inject the wife's eggs and to have a normal pregnancy rate. So for 60% of cases of non-obstructive asospermia, there is an answer, and we wouldn't recommend donor sperm. And for virtually 100% of cases of obstructive asospermia, there's a ready answer for it.
We have another question from Lucy. What is a good BMI to have when going through IVF and an embryo transfer?
Okay, so BMI is a abbreviation for body mass index, and it's just simply a matter of, there's a little chart for it, and it's just dividing your weight by your height, but it's very, very misleading. So most people say your BMI, if it's over 30, that's obese, and if it's under 30, you may be overweight, but it's okay. But that is really completely misleading. And because people may have denser bone structure, stronger, denser muscles, and so a high BMI does not necessarily mean a high amount of body fat, actually. And so I have to go by seeing the patient. I can eyeball them and immediately know whether they've got so much body fat that it might interfere with the quality of the IVF. But most people who have a difficult time losing weight can lose weight if they're getting pregnant. Depends on it. they can stop smoking, just like that, if getting pregnant depends upon it. But if someone is overweight, we'll prefer to use our mini IVF protocol because it's basically depends on a pill, Clomid, which is absorbed very well and doesn't depend on subcutaneous shots, which may not be absorbed very well. So mini IVF is an answer for the overweight woman.
We have a question from Ronita. It's been a year of trying and we are not sure what the problem is. Should we seek an infertility clinic or go to a reproductive endocrinologist for lab work?
Well, the major indication for having treatment, of course, is 1 year of not getting pregnant with unprotected intercourse. I'm wondering what her age is. Did she tell you that in her question? No.
She did not.
So it depends a lot on age. If she's in her 20s, she can maybe take her time and try for longer. But if she's in her 30s, she doesn't have much time to waste. And I would recommend that if it's been more than a year of infertility, then it's time to go to IVF. Now, that may sound too aggressive, so let me explain what I mean. Often, doctors will recommend first IUI. I've been in this profession for a long, long time. I think I'm the longest living infertility doctor in the entire world. And so I've been here long before IVF, and I know that, and before IUI, and I know that timed intercourse is just as good as IUI. And IUI only works because you're stimulating ovulation, you're trying to get more eggs or better eggs. But IUI won't be any better than timed intercourse. I mean, it's fun. I've got to give you maybe it's a diversion, but it's interesting. Where did IUI come from? Well, everybody does IUI, and the doctors make money doing it. The patient feels they're doing something active, and it's not as good as intercourse and ovulation induction. So why IUI? Well, in the early days of IVF, nobody really knew what they were doing very well. In the United States, it was developed in England and Australia originally. And so in 1982, when all the infertility doctors felt so inadequate because they didn't know how to set up cell culture or an IVF lab, it was really foreign to them. So Val Davijan, a great guy from University of Southern California, said, well, you don't have to do IVF. You can take the sperm, put it in a regular urinalysis centrifuge with media or saline, wash the sperm, and then when you wash that sperm, you can put it through what was then an infant feeding tube into the woman's uterus, and it's as good as IVF, and anybody can do it. So it became extremely popular because of that. And when you look at control studies, it's absolutely no better than intercourse. Now, IVF is at least 10 times better in terms of pregnancy rate than IUI. So IVF is a big deal. But IUI it's common, it's done everywhere by everyone, but it's pretty stupid. So to answer your question, wherever you go, whether it's to an infertility doctor or an IVF clinic or your regular OBGYN, you really got to be knowledgeable. You got to really understand and learn and question and expect that there's going to be some controversy, and you have to decide who makes the most sense.
We have a question from Mark. I am a 47-year-old male that had a vasectomy done just under 20 years ago. Is having it reversed and being successful a realistic option?
Well, having a reversal of a vasectomy, even if it was 20 years ago, is absolutely a realistic option. But I have to warn you that vasectomy causes pressure buildup that you may not feel in this microscopic system going all the way back to the testes. And this pressure causes little blowouts. I don't want to scare you, but little blowouts you don't feel. They're not dangerous, but little blowouts in the more delicate ducts that convey sperm from the testes to the vas. It's called the epididymis. So these epididymal blowouts will cause another blockage closer to the testicle. So just putting the vas together in most hands is not going to be successful because you've still got blockage in the epididymis. And so, but if we do a vas to epididymal repair, which is much more delicate and really a bigger operation, then the success rate in our hands is 95%. But It looks like it ought to be painful because it's a very big operation to bypass all that epididymal tubule. So we'll inject with a long-acting anesthetic after the operation's over. Of course, you're asleep for the operation. And before you wake up, we inject with a long-acting anesthetic. And you should have virtually no pain afterwards. So don't be frightened by the fact that it's a big operation.
Dr. Silber, do you have an age cutoff for women to use their own eggs?
Well, we don't encourage it for women over 47. Now, the pregnancy rate is really low for women who are 47 and 46 and even 45. But with our approach, mini IVF and freezing and storing and collecting a greater and greater number of embryos, we have pregnancies in all age groups up to and including age 47. And the pregnancy rate is very, very solid and very, very good up to age 44 and early age 45. But the methodology involves minimal stimulation to get a smaller number of the best quality eggs, freeze the embryos, save them, and do several more cycles to store up as many embryos as you can, because the pregnancy rate per embryo will be lower in that age group. And so we have to have a simple method of IVF that's tolerable to the patient, where they can come back for more and more cycles, and that really works. But if you try to overdose with huge doses of hormones in an older woman, first place, you're not going to get more embryos. You're not going to get more eggs. You can't. The eggs that are there in your initial antral follicle count are the eggs that are there. And you can just give humongous doses, and it will not increase the number of eggs, but it will decrease the quality of the eggs. And so that's why mini IVF is really particularly appropriate for older women and women with small numbers of eggs.
Okay, we have a question from Dawn. Do you have to have a referral from a doctor to make an appointment with you?
Well, no, the question is, do you need a referral from a doctor to make an appointment? No, absolutely not. In fact, really, in IVF around the country nowadays, patients are just really calling up the clinic directly, and they're avoiding the middleman, so to speak. Sometimes when you might be talking to your primary care doctor or your gynecologist, there could be a lot of delay while they try simpler treatments, and during that delay you're getting older and your eggs are getting older. So women are pretty sophisticated about this nowadays, and most of the time they're calling the clinic directly. So no, you don't have to have a referral.
We have a question from Jessica. My husband had a successful reversal a few years ago from Dr. Silber, and just found out that I have low progesterone, which will cause infertility on my part. Or can progesterone pills help my fertility? I am 32.
Well, 32 is great. I mean, you're still pretty young. Low progesterone itself is not usually the primary problem. It is usually caused by poor ovulation or ovulatory dysfunction. So I don't think that just giving you progesterone is going to improve your chance of pregnancy. Now, honestly, I don't know who you are from the question or what the problem is, but perhaps I should see you, or someone should see you, but I do not believe that the low progesterone is the primary problem. It's caused by a hormonal problem that needs to be addressed.
We have a question from Jan. I am 41 years old and just had my second failed IUI. How many more IUIs would you suggest before moving on to IVF?
Well, at that age, I wouldn't have even recommended 2 IUIs. I'm sorry to say that, but you really got to go right to IVF, because at age 41, you really don't have much time left, and you need to go to the most efficient, most effective treatment. And I was talking about this earlier in this Facebook Live discussion, that often women go through these less effective treatments thinking that that's the first step, but all that happens is their eggs are getting older rapidly while they're doing it, and so delaying the more appropriate treatment is really reducing your chances of having a pregnancy even with IVF. So no, go right to IVF now.
We have a question from Amber. Do you typically recommend IVF with PGD for couples where both parties are cystic fibrosis carriers?
Well, okay, PGD means pre-implantation genetic diagnosis. So, of course, if both couples are carriers, there is 25% of the embryos are going to have cystic fibrosis and actually have the disease. And 25% won't even be carriers, and 50% will be carriers but not have the disease. So it's up to the couple, but we would very strongly recommend PGD for cystic fibrosis carriers if both couples are carriers, and then we can diagnose which embryos would have the disease and which embryos would be normal. PGD is very accurate for this.
We have a question from Fran. I am 33 years old and have adenomyosis. Would you recommend I go straight to IVF, or what would be my chances of conceiving naturally?
So the question is, she has adenomyosis, and that is, I ought to tell the listeners what that is. That means that endometrial lining, or lining of the uterus, is invading the muscle of the uterus. It's not cancer. It sounds like it's cancer, but it's not. But it's a benign invasion of the uterine muscle with endometrial cells. Now, it can be a minor adenomyosis, just a small amount of it. Adenomyosis or endometriosis of the uterus. It can be a minor amount, in which case it's not going to interfere with getting pregnant. Or it can be a major, huge amount, and it will interfere with getting pregnant. Usually, if it's a huge amount of adenomyosis, and we can see that on ultrasound very easily, usually if it's a big amount of adenomyosis, you will have very painful periods, prolonged periods. It'll really be miserable, and you want to have something done about it. But if it's a minor adenomyosis, then your periods won't be so terrible. In any event, anybody with adenomyosis should try to get pregnant as soon as they can and not wait around for that. If it's a big amount of adenomyosis, we're one of the few centers in the United States that can operate on that. We actually learned it from Dr. Osada in Tokyo, and it's a big operation. But if it's a big adenomyosis, that would have to be fixed, most of the time doctors will recommend just removing the uterus. But if you want to have a baby, the better bet is to remove the adenomyosis. It's not like fibroids. Fibroids are easy to shell out. They've got a capsule. Adenomyosis is diffusely distributed, and it really requires a special reconstructive operation to fix that.
We have a question from Tanya. After IVF, what is the difference between progesterone injections versus vaginal suppositories? Is one better after an embryo transfer than the other?
So the question is, we always know after IVF we want to put people on progesterone supplementation for many reasons, but the so-called luteal phase just is not going to be adequate without progesterone supplementation after IVF. The question is, do we give it by shots, which are uncomfortable? They're intramuscular shots in the rear end. Or do you give it with a vaginal capsule or a vaginal foam or cream? And it's been hotly debated. Now, in America, most good centers give it by shots because women actually prefer that because it's just once a day. You can do it in the evening. You don't have to worry about it the rest of the day. If you give it vaginally, as is commonly the case in Europe, then the pregnancy rate is generally lower. We know their pregnancy rates are 15% lower than ours are. And the question is why? Well, I think that their labs are great, their doctors are really smart, and I think the problem is simply that they use vaginal progesterone. Now, you can get around that. If you use the vaginal progesterone 3 times a day, not just once or twice a day, then you'll get enough progesterone level that it's as good as the progesterone injection, just as good. But American women, by and large, for whatever cultural reasons, prefer the shot once a day to having a vaginal cream 3 times a day that they can't forget to use. Because if you forget it, then you won't get pregnant. So you have to decide what you want. Most American women prefer the shot.
Can genetic testing improve our pregnancy chances?
Well, this is the question that is just a hot one. Can genetic testing improve our pregnancy chances? Well, first you got to understand we're not talking about really testing all your genes. It's a very simple thing, testing for the number of chromosomes. And it's become very popular in IVF centers, I think, for two reasons. One is it increases the income from any given cycle in a patient, so it's an enormous, enormous money spinner. But the second reason is that it will increase your pregnancy rate per embryo transfer, but it will not increase your pregnancy rate per cycle or per egg. In fact, in older women, it will lower your pregnancy rate per egg or per cycle. And the reason is that it's prone to errors because human embryos are mosaics. I'll explain what a mosaic is. It means that our trophectoderm, or the cells that we would biopsy, consists of normal cells and abnormal cells. Cells with a normal number of chromosomes, cells with an abnormal number of chromosomes. So your biopsy is usually a mixture, and if it's not a mixture, it still could be an error. You could biopsy abnormal cells, and that could be a normal baby. You could biopsy normal cells, and it could be no baby. So there's so much error in this PGS. We shouldn't call it PGD or genetic testing. It's PGS. It's just screening. That's all it is screening for the number of chromosomes. Now, for a woman who's young and has recurrent miscarriage and is sick of the miscarriages, it'll reduce her miscarriage rate, and that's good. We've done a lot of this. We were doing this long before any of the people currently practicing it were doing it. I mean, we've had a 15-year, almost 20-year history of doing this and writing papers on it. So we know that it's useful for those cases, and it's also useful for trying to understand certain women have gone through multiple IVF cycles with good quality embryos and still haven't gotten pregnant. So for those cases, it can give us some information. And it can be misleading information because of the error rate, but it can give you some information and improve the live baby rate for women with recurrent miscarriage. But overall, it reduces the pregnancy rate and the baby rate because there's an intrinsic error. And we talked about that in New York just last weekend. We had a huge conference and discussion about it. And patients are naive about this. And most of the doctors, they just send the sample off to their 3 or 4 labs that make a lot of money doing this. And it's become an enormous financial industry. This industrialization is really hurting many patients. So PGS should be limited to people that either have a specific gene carrier defect or to young women with recurrent miscarriage or to women with unexplained recurrent failure to implant with IVF. And those are very unusual conditions. It really is not a common indication.
Okay, Dr. Silber, we have our last question from Katie. Is there anything we can do or not do to help an embryo implant?
Well, yes. I mean, the most important thing to help an embryo implant, there are a lot of things. You've got to try to relax by meditation. Some people use acupuncture, but we ask them to meditate, and that meditation helps relax the uterine muscle, because the uterine muscle has spasms, and anxiety will increase the spasm rate. So that's one thing you can do. Another thing is you really have to have a doctor who does a very, very gentle transfer with the softest possible catheter. That's often not so easy as you might think it is. We do it with ultrasound guidance, and that means your bladder has to be full so we can actually see the catheter through the bladder with ultrasound on your abdominal wall rather than in the vagina. And so it must be a very delicate transfer. Now, there is a controversial idea that may work, and we haven't got yet good control studies, but it doesn't hurt, we know that. And that is a woman who's had a failure to implant with really good-looking embryos. We can do what's called a uterine scratch. It's like a mild curettage with an endometrial curette. Very simple thing done under local anesthesia. It's a 2-minute procedure. It's not harmful, but my view of how it works is this. It's scientific. Humans are the only animals that menstruate, really, that have a complete sloughing of their uterine lining every month with replacement with a new uterine lining. Somehow or other, that must be important for implantation of the human embryo. And so if you have a lining that is not functioning right, this scratch will give you a brand new lining in the next cycle. And I think that's why it appears most IVF doctors think that it works, and I think that's the reason why it would help.
Okay, Dr. Silber, that was our last question for tonight.
Okay, so you can tune in for another Facebook Live with us, Infertility Center of St. Louis, in May. And our phone number, if you have any questions, is 314-576-1400. And you can also just go to infertile.com. Thank you.
Thank you.